You see, Saumil talk is of most importance, penultimate talk, very relevant because you see one of the commonest complaint, flashes, floaters, occasional flashes. Then on finding we get some pigmented spot somewhere, some hole atrophic somewhere. A lot of people believe HST is the only reason we should do prophylaxis. I think Tinku also showed one slide on prophylaxis of a tear. So some people say vitreous is the culprit. So what should be done, Saumil, in prophylaxis in RD surgery? What should be done?
Thank you, sir, for the kind invite. Actually, this topic more or less looks like a postgraduate level presentation if this lesion has to be barraged or not for that lesion. So I don't want to make it that. So I'm going to be presenting a lot of radical stuff here. And I hope Dr. Lalit Verma will continue to invite me despite my radicalization of the concept. So that is why the name of the concept is RD prophylaxis WTF. What's the fun? So preferred practice patterns say I believe more in practical practice patterns. We are not here to pinpoint कि ये lesion को laser करो या वो lesion को laser करो. Let's say we laser all the lesions. Pigment हो या horseshoe tear हो. What's the harm is what we normally say. But what is the cause of retinal detachment? There's only one cause. It's posterior vitreous detachment. Irrespective of whether you have a pigment or a break or any other lesion in the retina, nothing is going to detach unless you have posterior vitreous detachment. So if that is the cause, what should be the solution technically? Remove the vitreous vitrectomy. Because again, the same issue, what's the harm? And I'll come to this. Age-related vitreous degeneration is a similar term like age-related macular degeneration. Just as aging is inevitable, posterior vitreous detachment is inevitable. It's going to happen. And you begin with floaters and flashes, then you may or may not develop a bleed. You may develop a tear, which may go full and it becomes an operculated hole. And finally, the retina lifts off, in which case you get retinal detachment. Now, what happens typically in a PVD? You have something called static traction, something called dynamic traction. Dynamic traction means vitreous has two parts, completely detached vitreous and a small area of attached vitreous, and that is where the shearing force develops. You see the HST here, anything anterior to that is static vitreous attached at the vitreous base. And this is the dynamic mobile vitreous, and that is what actually tears the retina. So when you say that, Baba, which part of the retina will tear over here? It could be even the normal retina as well as the seemingly normal retina. We were talking about lesions here. At the attachment of the vessels, vitreous attachment of the vessels are also very stout points. And the margin of the vitreous base, what I talk about, they are also stout points where the vitreous can result in a hot. Lesions are just not enough. And the whole premise of my discussion is that if there is a 50-50 chance, 50% chance that the retina will create breaks at the site of lesions versus 50% chance that it can create breaks anywhere in the normal retina and result in retinal detachment, then why should we actually laser the lesions? What's the use? Yes, definitely will reduce half the risk, but we know that there is a 50% chance still that tears or holes may be produced in a completely normal retina. In fact, when I say PVD is a culprit, what you should address, which will reduce 100% of the risk, we should go more on the discussion of PVD as to the describing the types of PVD, which are the less dangerous, which are the more dangerous. The less dangerous ones are usually phakic eyes, younger patients, usually non-violent or asymptomatic PED. If they do happen in younger patients, yes, they could turn violent, but especially patients with a highly symptomatic PVD, floaters and fasces, especially that have a family history of RD or other eye RD, moderate myopia, again, not very low myopia, not very severe myopia. In severe myopia, the vitreous is more or less liquefied. It's synerized. It does not exert too much of traction. Ophthalmodonetic conditions like pseudophakia with a yak cap, with a PC rent or an aphakic situation where there is too much mobility of the vitreous or vitreous diseases per se like Marfan's or Stickler syndrome. So when you see irrespective, see I've clearly, irrespective of peripheral retinal lesions, if you just have a violent PVD, the incidence of RD increases depending upon the violence of the PVD. Pseudophakia 0.2%, myopia slightly more violent PVD 2%, pseudophakia with PC rent or yak cap again 2%, aphakia 4%. Family history of RD or other eye RD, the incidence of RD in the other eye is practically 8%. So then what is the use of actually lasering those lesions when PVD is the primary culprit? There is certain logic to this as well. When you have peripheral retinal lesions, there's a very busy slide. I'm going to just put a gist of it. It is divided into benign lesions, a kind of lesions that is never going to develop a hole or a tear, and malignant lesions, which at some point in time could develop a hole or a tear. In benign lesions, these are basically, you can just go through them: intraretinal microcystoid, snowflake, pearl, white with pressure, dark without pressure, so on and so forth. Not going into the details. Malignant lesions can be classified into low risk and high risk, with the primary categories being lattice spectrum and non-lattice spectrum. Lattice spectrum में low risk is ill-formed lattice, moderate risk is yes radial lattice or pigmentous lattice, high risk is probably snail track or lattice with holes or lattice with traction at the edge. Non-lattice is your retinoschitic conditions, white without pressure, and when you have moderate risk, retinoschisis with outer layer breaks, white without pressure in Marfan's or Stickler syndrome, and even chorioretinal atrophy because vitreous is tightly adherent. This is where even laser comes in. If you give laser for these lesions, it is a low risk because it involves tightly formed vitreoretinal adhesions where also a tear can be produced. So one category is low risk, one category is moderate risk, and the other category is high risk. So when you principally divide all these lesions into two primary parts, moderate to high risk and low risk, and you classify the PVDs in the increasing order of their severity, you realize that ultimately you got to treat a whole lot of them. The only two places or three places where you do not treat is when you have a symptomatic PVD, which is with a very low risk peripheral retinal lesion. And why you should even leave that? Because, as I said, what's the harm? In fact, you realize here that even in a normal retina, at the margin of the vitreous base or at the attachment of the vessel, if you can get a tear, what will you really laser? Because you don't know where it is going to detach, where it is going to first start a tear. So in these cases, some people have even proposed do a three the posterior margin of the vitreous base so that even when tears develop, nothing happens. So again, here, what's the harm in doing a 360 laser? And this is where the harm lies. So I will go into the first situation, normal retina periphery, like everywhere else. A situation which is like this. What is the risk of developing RD? Everything is in multiples of 2, so it's easy to understand. 0.002%. Benign peripheral retinal lesions like paving stone degeneration, something like this. Okay, what is the risk of developing RD? Again, 0.002%. Low risk peripheral retinal lesions, lattice and non-lattice, is 0.02%. Laser CRA also falls into low risk, so giving the same percentage 0.02. So any condition upward of this you have, laser is going to be a safer option? No. You're going to leave it just like that. In fact, laser is going to have a higher incidence of RD as compared to these conditions. So benign peripheral retinal lesions, normal retina, not really required. Normal retina periphery with vitreous base and blood vessel involvement, I would put it at moderate risk. This lesion is at moderate risk. So maybe you would attempt a 360 laser in that because laser is producing a lesser risk as compared to this situation. We'll discuss about that. Other moderate risk conditions and high risk conditions definitely would laser because the incidence of developing RD is 0.2 and 2%. Now here comes 360 laser. In fact, 360 laser works reverse. As the literature points 20% propensity of causing RD. It is like you've shifted the vitreous base from there and you created another vitreous base, which also creates a shearing force. Tears and holes probably has the same propensity as a 360 laser. So if you feel that there are multiple tears in the retina, you can still attempt a 360 laser. So laser lies in these two places. Uh, we've just been through this. Last one or two slides more. So one cause of RD, posterior vitreous detachment. What's the harm in doing vitrectomy? I would ask a reverse question. What's the good in doing vitrectomy? You avoid not only RD, you avoid vitreous hemorrhage, you avoid formation of ERM, you avoid VMT, full thickness macular hole, lamellar hole, all the interface disorders which Dr. Lalit Verma just talked about. Even avoid PDR. You may go up to NPDR, but you avoid EDR. So that's the good. And you may not do vitrectomy in all cases, like how Dr. Lalit Verma just mentioned. ERM, we don't do in everyone. We won't do vitrectomy in everyone. But yes, patients above 40, especially who have high myopia, who are pseudophakic with a PC rent or have developed a phakic condition, family history of RD, other eye RD, yes, I would rather propose doing a complete vitrectomy than doing a laser barrage. So that's a good. Thank you.
Thank you, Somil, for. I thought this topic, was worth a debate actually, rather than laying down some guidelines for. You see what you can be ready on the next slide. So we'll have last talk, and but some discussion has to be there on Somil's because what you're saying is like cataract surgeon do any fakey guy do a cataract surgery. What you're saying is if patient is symptomatic, do a vitrectomy for all 40 above. That's what you're trying to say.
Don't do anything. Just by lasering peripheral lesions, if you feel that you're protected against an RD, that's not the case. You may do it for your satisfaction, but that's not going to actually protect you because there's a 50% chance of developing tears in an area that have not been lasered or there are no lesions.
So what is your reaction, AG, on this? He says that "Hare ki vitrectomy kar do." No, very.
Until unless what we call as a floatrectomy, and we have done quite few patients who complain of a severe floater, but not all patients. The demand should come from the patient side, not from the surgeon side.
That's a different topic. We are talking
Yeah.
of a patient who has retinal tears. Retinal tears. Floatrectomy to baat alag hogi. Who has retinal tear. He says do a vitrectomy.
Patient ही नहीं मानते
Abhishek?
हैं sir.
No, not to you. Abhishek.
So I would, so my take is that in the retinal detachment course that we do, we always keep saying that laser barrage is not really effective, and that part of his I would agree to, that it is not really effective, and you don't need to barrage any non-symptomatic lesion, and only if the symptomatic lesion is in the zone of the posterior margin of the vitreous base. But vitrectomy forward.
Abhishek, political answer. Political answer. What I was wanting was horseshoe tear laser is a must. At least American Academy, every guideline says that you should. I agree. Those small, lateral holes we can observe. But he says do vitrectomy for all.
No, sir, I didn't say that. Sir, I said for HSTs, you do laser, but you're doing laser for every lesion in the retina. So I mentioned it. I've said that which lesions are below laser, which lesions are above laser in terms of risk capacity.